Hello, my name is Susan Gillespie. I am a family nurse practitioner. I will be guiding you through learning suturing skills for beginners. In this course, you'll be learning how to do the simple, basic interrupted suturing technique that you will be asked to demonstrate during your immersion weekend. Mind you that you also may see questions on your final exam that refers back to this course. This course is self-paced. You can watch it over and over. You have your suturing materials. You can practice to your heart's content. If you have any questions or concerns, feel free to reach out to me through the school email. You have several learning objectives. The first is that you will be able to describe the rationale behind wound closure. You will be able to demonstrate, using the simple interrupted suturing, the closure of a wound. You will also be able to identify common complications related to wound closure. It's really interesting to know that the basic principles of laceration repair really haven't changed in the last century, but we actually have some really great therapeutic options that are now available and a lot more innovative and rigorously studied. We have the development of topical anesthetics, tissue adhesives, and fast-absorbing sutures that has made the management of lacerations much less traumatic for the patient. And now we have the use of procedural sedation for some more difficult lacerations and for the extremely anxious child. Mind you, most of these fancy things may not be available to you in clinic. So we have goals of wound management that are simple, right? We want to avoid infection. We want to assist in hemostasis and provide an aesthetically pleasing scar. So the majority of the studies that are being done now are actually focusing on the aesthetic nature of wound healing rather than the infection rates, because the infection rates remain low regardless of how we manage these. So the signs and symptoms of lacerations we all know well. We have the bleeding with the option for foreign bodies in the tissue. You can see hematomas. There can be pain and numbness. There can be loss of motor control, diminished pulses, as well as delayed capillary refill. So I'd like to review the wound physiology and healing. Most of you have already learned this, but it's always good to have a nice refresher. So remember, we have the epidermis, dermis, and subcutaneous layer, and deep fascia. These are the layers that are concerned in any wound closure. The epidermis and dermis are very tightly adhered, and you cannot distinguish between them. They together constitute the skin. Dermal approximation provides the strength and alignment of skin closure. The subcutaneous layer is mainly composed of the adipose tissue. Nerve fibers, blood vessels, and hair follicles are also located here. Although this layer provides little strength and repair, sutures placed in the subcu layer may actually decrease the tension on the wound and improve that cosmetic result. The deep fascial layer is intermixed with muscle and occasionally requires repair in the deep lacerations. The healing process in skin occurs in several stages. First, we have the coagulation, which begins immediately following that injury. Vasospasm, as well as platelet aggregation and fibrous clot formation occur. During the inflammatory phase, proteolytic enzymes are released by the neutrophils and the macrophages break down the damaged tissue. Epithelialization occurs in the epidermis, which is the only layer capable of regeneration. Complete bridging and wound closure occurs within about 48 hours after the suturing. New blood vessels growth peaks about 4 days after the injury. Collagen formation, which is necessary to restore tensile strength to the wound. The process begins about 48 hours after the injury and peaks in that first week. Collagen production and remodeling continues for up to 12 months. So it's interesting to note that full healing of any wound does take a full year. Wound contraction occurs 3 to 4 days following the injury. The process is poorly understood, unfortunately. The full wound thickness moves towards the center of the wound, which may affect the final appearance of the wound. So it's important to also understand that there are some systemic disturbances that can influence wound healing. Systemic disturbance that influence wound healing. There are lots of these. They include renal insufficiency, diabetes, nutritional status, obesity, chemotherapeutic agents, corticosteroids, as well as anticoagulant and antiplatelet adhering drugs. Disorders of collagen synthesis can also cause problems, and these include Ehlers-Danlos syndrome as well as Marfan syndrome. And don't forget that patients of African or Asian ethnicity can be prone to that hypertrophic scar formation or keloids. Now, remind you that local disturbances are more common contributors to abnormal wound healing than the systemic disturbances. These factors include temperature, ischemia, tissue trauma, denervation, and infection. And it's interesting to know that temperature and blood supply and ischemia are so closely interrelated. The higher the temperature of the anatomic area, the greater the blood supply and the resultant oxygen delivery. Did you know that the temperature of the face can be up to 9 degrees warmer than the foot? So that results in less time that the sutures need to remain in the face, as well as lower infection rates. Different suturing techniques can contribute to tissue ischemia, especially the ventral mattress suture. You'll see it, but we're not going to do it. Vertical mattress sutures have been shown in animal studies to cause more ischemia than continuous or simple interrupted sutures. It's also important to know and note that infection can occur in any traumatic wound, and all acute wounds are contaminated to a certain degree. There's no such thing as a clean laceration. An infection occurs when there is an imbalance between the host resistance and bacterial inoculation. The mechanism of injury and the time from injury to potential repair are very important to consider. Crest injuries may be extensive cellular necrosis and higher infection rates than shear injuries due to the greater energy that's distributed over a larger area. An injury heavily contaminated with dirt, gravel, or other debris also has a higher infection risk. The length of time between injury and evaluation can also affect that infection risk. The management of minor laceration begins with the assessment and preparation of the wound, which includes that history. So to assess this wound, you need to determine the mechanism of injury. How old is this injury? You need to identify the possible contamination or foreign body. You need to assess the extent of this wound, which can be painful, so do not be afraid to numb the area up first before you explore. You also need to do an assessment for neurovascular compromise and tendon injury in the surrounding area. You have to check for if the patient needs tetanus prophylaxis and ID risk factors that might affect healing. So when you're doing that physical exam, you need to understand the indications. When are sutures appropriate? Sutures are appropriate when the depth of the wound will lead to excess scarring and the wound edges are not properly approximated. Typically, this is true whenever the laceration extends through the dermis. Some wounds amenable to closure with sutures may be better managed with an alternative technique, such as skin adhesive, which I absolutely love to use. People love it, keeps the wound clean. Doesn't always work if that laceration is deep, though. Wounds that are less than 5 centimeters and not under tension are the ones that you can really close with that skin adhesive. Clean, uninfected lacerations on any part of the body in healthy patients may be closed for up to 18 hours following the injury without a significant increase for the risk of infection. Facial wounds, however, may be closed up to 24 hours after injury. Now, mind you, there are select cases that closure of facial wounds may be done up to 72 hours after injury. These are not ones I recommend that we as practitioners in clinic do. These should be done more along the lines in an emergency room with the use of a skilled surgeon. All right, I want you to take this little question. The right answer will be available to you. If you have any questions, review the previous slide. This question is also same as this last question. You will have the right answer. If you get it wrong, please review 2 slides back. Moving into local anesthesia, we have a couple types that we can use. One is that topical, and then we have our local, with lidocaine and without lidocaine. Our next slide will have a great video that will review the options. Again, answer the question. The right answer will be noted. If you have any questions, review the video.
Good morning. This is Susan Gillespie. I am the nurse practitioner and your instructor for this class. I would like to show you today how to do a proper wound irrigation and cleaning of debris and making sure that there is no foreign bodies. All right, so you'll see in front of me today is I have our practice skin. I have tweezers and forceps, my irrigation. So the first thing I'm going to do is glove up. So we always want to make sure that we take care of ourselves first. Lacerations, you can use regular gloves. You do not have to have sterile gloves. So as you see from my skin, which that you have a copy of this skin in your kit at home, so we're going to use just a large bore syringe with a protected guide over the top. Wound cleansing is all about irrigation. We want to decrease that bacterial load, and the best way, per literature, is to irrigate. You can use normal saline, you can use tap water. Literature and evidence-based practice says that you can use both. So I've just drawn up regular tap water in a large bore syringe. Don't forget your guide, splashback is an issue, all right? So we're just gonna take this, we're gonna clean. You wanna clean away from you. All right, we have a lot of debris in here. Yep, see, splashback. All right, so I'm gonna grab some more water. And again, you'll see I'm just using normal tap water. Now on a human body, this would be on an arm or a leg, and you would have more of a, so I'm just going to use my fingers to pretend like that is. So I'm just cleaning this out. And you're going to see all the debris. Look at there, even a leaf. Okay, if you can't get all the debris, use your utensils. Let's get it out of there. Any foreign body that we have is at risk for infection. So you see I'm removing these. Okay, I'm going to just get a little bit more water. Okay, so now we have a nice clean surface. Now again, this is on our skin that we're using. Human bodies don't look this good, nor are they this clean. They will continue to bleed, but you really got to do copious amounts of irrigation. We want to lessen that bacterial load. Research says either tap water or normal saline is sufficient, but you want to do copious, and I mean copious. The more, the better. We want to dilute that bacterial load. That's one good way and the best way to prevent laceration-associated infections.
All right, we talked about suturing. One thing we didn't really get into is contraindications of suturing, and I do want to touch on that because this is so very important. So concerns about wound infection should never be your main reason not to close a wound primarily. Wounds that have been grossly contaminated with foreign debris that cannot be completely removed, infected tissue, or non-cosmetic wounds that have come to medical attention late, more than that 18 hours, should be allowed to heal by granulation, or otherwise known by as a secondary intention, basically allowing the body to heal itself. Of course, we still have to clean that wound. In addition, patient with risk factors for poor wound healing, such as the patient that are immunocompromised, has peripheral artery disease, diabetes, may warrant delayed primary closure depending on that age of that wound, again, over 18 hours, or where the wound is. Other situation in which closure with sutures may not be appropriate would be animal bites, especially in non-cosmetic areas, which of course is usually your hands or your feet. We do that because they have a high risk of infection. A deep puncture wound that we can't clean out well enough with irrigation. Wounds in which suturing will cause too much tension, so it will cause puckering. In this instant, healing by secondary intention with later scar revision may be the best way to go. Wounds that are actively bleeding with the source is arterial. With the exception of scalp wounds, we need to make sure that we obtain hemostasis so that we don't get a subcutaneous hematoma and we don't create more risk for infection as well, which of course will impede healing. And superficial infections that are expected to heal without significant scarring, such as small lacerations, abrasions that only involve the epidermis. So think of a scratch. Suturing these wounds will potentially cause increased scar formation and the risk for infection. So there are definitely contraindications to suturing. Our next video is going to get into detail of the simple interrupted, which you will be asked to perform in immersion weekend. All right, now it is time to get out your suture practice kit. Each one of you should have already ordered this kit and should have it delivered. Again, this is easily found on Amazon and it's like $38, so super easy to find and super easy to get, as well as you can get more suture material from Amazon as well. All right, I want to review the different tools. So we have here this number one. This is your needle holder, okay? You'll notice it's blunt here. It has locking here. All right. Two, and you have two of these. These are your Addison's forceps. Three is your mosquito forceps, and you'll know that the mosquito is that nice curved here, as well as a locking mechanism here. Four, it will be your iris scissors. These are the nice straight scissors here, nice and sharp. And five is your scalpel knife holder, which we won't be using this one at all right now. You can use either the 4.0 nylon or the 4.0 silk braided. Again, you can reuse these and you can order more if you feel like you need more practice. Again, easily to find on Amazon. You may even talk to your clinic and see if they have any ones that have expired. Now it's time to take everything that you have learned and practice. You're not going to get it right the first time. You're going to get frustrated. Take deep breaths and just keep trying. Review the video over and over and over. This material that you're practicing on is similar to skin. It's not skin. But again, this is a great way to practice. Watch people. Pull up other videos on YouTube and practice some more. Again, reach out if you have any questions or concerns.